Thanks, Dr. Nayak, for good introduction. We will just scan through few pathologies in the eye and see how ultrasound is really helpful for us to evaluate the eye. When I started off doing B scans, we used to use 10 megahertz probe. We still use the 10 megahertz probe, which actually is a standard probe which comes with all ultrasound machines. Then we started using the 20 megahertz probe. I'll tell you the advantages of that. It's not a routine requirement in your day-to-day practice. Then we use the 50 megahertz probe for the UBM, but this talk is restricted only to V scan. So just as a summary of what have I learned and where do we stand and what is the future. We start off with the vitreous cavity, and as you know, there are echoes and membranes and mass lesions. There are three things that are possible in the vitreous cavity, and these are the different types of echoes that we can see, all of them in one go. Ultrasound does not tell us whether an echo is a vitreous hemorrhage or a vitreous inflammation. It's actually a clinical diagnosis. There is no ultrasound feature which says this is hemorrhage or this is inflammation. You have to have a clinical picture in your mind. These are just floaters. Okay, they are low level echoes spread out uniformly in the vitreous cavity, and they extend right up to the retina. On A scan, the reflectivity is less than 25%. Coming to here, these are again bright echoes uniformly distributed within the vitreous cavity, but the reflectivity is high. So this is asteroid hyalosis, and these are floaters. So these are conditions which are not so much of a harmful to the patient, but they looks drastic on a B scan. And now we have these two cases. This is inflammation, and that is vitreous hemorrhage. Again, I will repeat that ultrasound does not tell us that these are inflammatory echoes or they are hemorrhagic echoes. But if we look very carefully, usually inflammation is more at the posterior pole and hemorrhage is more in the center of the vitreous cavity to begin with. Inflammation can later on progress and thicken the chorioretinal layer, forming vitritis to endophthalmitis and even panophthalmitis. Whereas generally with vitreous hemorrhage, the chorioretinal layer is not thickened. So these are just a point to be noted, but otherwise still it is a clinical picture which tells us what is what. Okay. Coming to vitreous inflammation, right? The role of ultrasound is to tell us what is the stage of inflammation, which will help the surgeon to decide what is the next course of action. These are just vitreous inflammation, but you can see that there is thickening of the chorioretinal layer. Why does that thickening occur? It is inflammation of the choroid, and the choroid gets inflamed and they become hypoechoic. So you start seeing the thickening of the choroid. So this is endophthalmitis, from vitreous to endophthalmitis. And then when it goes out into the tenon space and there is fluid in the tenon space, it becomes panophthalmitis. So we can judge the extent of inflammation from ultrasound point of view. What is the type of inflammation can we make out on ultrasound? Really not possible. But these are two types of inflammation which can be of some sort of surety from an ultrasound image. And one is posterior scleritis. This is an exam spot. This is always asked for everywhere in an exam, where there is thickening of the chorioretinal layer more at the posterior pole, and it thins out as we go anteriorly. There is fluid in the tenon space at the optic nerve, and there is thickening of the optic nerve. So this is a T sign of posterior scleritis. Now coming to another thing, that is the vitreous hemorrhage. I would like to tell you that vitreous hemorrhage, when in an acute stage, that is within the first 12 to 24 hours, if the patient presents to you, you see a red glow, and if you ask for an ultrasound, usually the ultrasound comes as normal, because the blood at that stage is in fluid state, and that between that and the vitreous there are no interfaces. Therefore the ultrasound will come as normal. But as within 24 hours or within one day, few echoes start developing in the vitreous cavity, and then we start seeing small dots and lines. That's more of a vitreous hemorrhage. Then the vitreous hemorrhage sort of organize and form, looks like a mass, but it's actually more of organization of echoes, and it looks more in the center of the vitreous cavity. Finally, it will organize and form multiple membranes, and this is the third stage of vitreous hemorrhage. So we need to find out where those membranes are attached. This is attached just temporal to the optic disc. So this is the macula, and this is macular elevation out here. So depending on where the membranes are attached, we can find out what is the status of the retina, and it can help plan the treatment accordingly. Again, before we go ahead, I want to show you that this is vitreous hemorrhage and this is vitreous inflammation. Okay. See, they both look similar. It is more of a clinical diagnosis. Coming to membranes in the vitreous cavity, right? We are looking at retinal detachment, vitreous detachment, choroidal detachment, and vitreous membranes. So how do we differentiate an RD from a PVD? If it is not attached to the disc, then it's more likely to be PVD, because RD is usually always attached to the disc. Thick uniform membrane, that's the hallmark of an RD, right? It is a thick membrane which is uniform in its texture, whereas vitreous detachment is a thin undulating membrane. See the irregularity of the texture of an RD versus a vitreous detachment. These are three examples of vitreous detachment, and this is one example of RD. I would just like you to appreciate the difference in the texture of the membrane. That helps us more than any other point of differentiating an RD from a PVD. So amongst the three most important points which will help us to differentiate an RD from a PVD, one is a thick uniform membrane, no after movements. If you move the eyeball, the RD does not move, and it has 80 to 100% reflectivity almost up to the periphery, whereas PVD is a thin undulating membrane having good after movement, and the reflectivity reduces as you go from the center to the periphery. Now, post-operative retinal detachment actually is quite a bit of a challenge from an ultrasound point of view. So when a RD has been operated, it's usually sent to us whenever there is a vitreous hemorrhage, when they cannot see what is the status of the retina, and you want to know whether there is a secondary detachment or not. So this was a scleral buccal which was done. This is the buccal. We can see the shadowing from the buccal, and here we can see that there is a membrane from the optic disc going up to the buccal. So this is recurrent RD following a retinal detachment surgery. This is always we see a small little echogenic area in the anterior part of the vitreous, just behind the pars plana. This is called as a vitreous skirt, and this is a normal finding post vitrectomy. It's not at all abnormal. Usually see it at the anterior part. Should not be confused with any PVD or an RD. This is just plain vitreous hemorrhage following and vitrectomy, but no RD. And sometimes we normally, after a retinal detachment surgery, we see small elevated membranes at the periphery, and we think that they are RD. Normally one should not jump to a conclusion of an RD, but follow up this membrane. Sometimes fluid can just accumulate between the retina and the choroid in post-operative status, and if we follow up, this fluid gets absorbed and the membranes resolves. Now, I want to show 2-3 slides where we have a similar clinical situation, but ultrasound helps us to make a differential diagnosis between two different conditions altogether. I had this child with leukocoria, which presented to us, almost white pupil. We had nothing going on. If you see in these two cases, they have a very similar ultrasound finding, but they are two different pathologies altogether. This EV. So this is the two differential points. They are two similar clinical condition having a little similar ultrasound findings, but have two different pathologies altogether. Coming to another case when you have again completely opacified vitreous cavity, completely opacified cornea, and you want to know what is the status of what is happening in the vitreous cavity. Look at these two pictures. They are quite similar. If you appreciate here carefully, there is a sort of a Y-shaped different echo texture membrane, or we can say a different echo texture structure coming into the center. This is a case of closed funnel detachment, long-standing detachment, where there is deposition of the subretinal echoes, which have become so bright over a period of time, so the RD looks hypoechoic. Normally it is echogenic. Whereas here there is no membrane anywhere. This is organized vitreous hemorrhage. There is no retinal detachment. Again, a similar clinical condition, two different pathologies on ultrasound. Look at this case. This is like a very drastic condition that we sometimes face following a cataract surgery or following a very serious trauma. So whenever there is bleeding on table for a cataract surgery, it's always a drastic situation for us, and we are scared. We are not sure what is happening in the vitreous cavity, because that's where the bleeding is coming from. Look at those two patients. Very similar clinical findings, same clinical situation. Ultrasound also remains the same. Whereas if you see here, there are echoes which are occupying the entire vitreous cavity. In front of the optic disc, there is also a few echoes. Look at this condition here. Again, completely opacified vitreous, but in front of the optic disc, we can see a triangular shaped hypoechoic area. This is expulsive hemorrhage. complete kissing choroidal detachment with suprachoroidal hemorrhage, and this is just vitreous hemorrhage. Both can occur in a post-operative scenario where we have bleeding on a table, and they are again have a similar clinical picture, again a similar ultrasound picture, but if you look carefully, they are two different pathologies. Here is a vitreous hemorrhage, and this is suprachoroidal hemorrhage. This will resolve on its own. This something will have to be done. Coming to mass lesions within the vitreous cavity. First one, as Dr. Nayak showed, case of retinoblastoma. Remember that when we are evaluating leukocoria, the most important thing is to look at the axial length. If the axial length is normal or increased, it is retinoblastoma, because all the other conditions which are DDs of leukocoria or stimulate a retinoblastoma have reduced axial length, each and every one of them. So axial length is very important. Mass is, if you see a mass, then most important is to see for calcification. So calcification, whenever it is present, yes, it can be a retinoblastoma, but calcification is only present in 50% of retinoblastoma. So when I look at the A scan, the high irregular reflectivity of A scan is a hallmark of a retinoblastoma. Sometimes we need to play around with the gains of the machine. The machine actually has a gains and a lot of amplification factors inside. You look at this retinoblastoma with small echogenic areas inside. It looks like calcification, but not very sure. It's not so shadowing. If you reduce the gains, you see that the calcifications are strikingly seen. So the machine is there. We can really utilize the machine very well. Okay. Now, these are the differential diagnoses of leukocoria. Again, I told you all of these conditions have a reduced axial length. This is ROP, grade 4 and grade 5 ROP is what we see on ultrasound, where there is a closed funnel detachment, but lot of echoes just behind the lens. It's also called as retrolental fibroplasia. Again, a closed funnel detachment, but very bright subretinal space. This bright subretinal space is because of deposition of cholesterol here. So this is Coates disease, whereas this is PHPV, as I told you, a thick membrane attached from the posterior pole anteriorly, right? So these are three differential diagnoses that we look for. Another mass which is of importance to us is in an adult age group, and that's choroidal melanoma and the differential diagnosis of choroidal melanoma. Melanoma is one of the only condition, only malignant tumor in the human body which has a very characteristic appearance on an ultrasound. And why is that characteristic appearance? Because melanoma is the only tumor where the cells within the melanoma are uniformly distributed. By definition, malignancy means irregular proliferation of the cells. Whereas in a melanoma, the cells are uniformly distributed, and therefore all the features that we see of on B scan and A scan of a melanoma are in conjunction with this appearance of the tumor. So it is seen as a hypoechoic or echogenic tumor without any interfaces inside. Why? Because there are uniform distributed cells inside. It has an increased vascularity on Doppler, and on A scan it has this classical cascading reflectivity. That means when the ultrasound hits for the vitreous to the mass, there's a bright spike, and as you go inside, the spike reduces. Why? Because there are no interfaces inside, and therefore you see this classical appearance, which is pathognomonic of a melanoma. There's the same thing over here. Coming to a differential tumor, which is a differential diagnosis of melanoma, is a choroidal hemangioma, which sometimes mimics a melanoma because of its texture. But usually in a hemangioma, we will always see a very bright echo over the surface of a hemangioma, which is a phlebolith. So this phlebolith, if you see over here, and this phlebolith needs to be highlighted by reducing the gains of the machine, then we are sure that it is a hemangioma and not a melanoma, because that will make a huge difference to the differential diagnosis. Coming to, I already described you a case of suprachoroidal hemorrhage, but I am working on, again telling you that we need to play around with the machine in front of us. This was a case of a mass sort of a lesion which came to me as suspected melanoma, and I did the ultrasound. You can see here that it looks like a mass with irregular texture there, but there looks to be a membrane in front. I was not sure whether it is a melanoma or just a hemorrhage. So I reduced the gains. You look here, this is T1, this is T2. T3. You see the hemorrhagic echoes have subsided and the choroidal detachment is strikingly seen. So this is a case of a localized suprachoroidal hemorrhage and not a mass lesion. So that machine they present in front of us is of immense help, and one should utilize all the functions of the machine. This was a real googly to me. This was a gentleman around 80-year-old air marshal working in an air force and was hypertensive. He presented to me on day 1 something like this. Clinically suspected to be a case of choroidal metastasis. He had a tumor, a prostate removed for about 10 years back, but otherwise he was absolutely fine. It looked like a lobulated lesion to me on day 1. You know, the optic nerve was somewhere here, and this looked like a lobulated mass. Even I said it is a choroidal metastasis. So he decided that he's not going to get 80-year-old, not get any treatment. He went to his village, just went away. And after 6 months, he came back and he said that, oh, I'm feeling fine. And he came to me for a repeat ultrasound. This is our ultrasound after 6 months. Okay. If you see here, the same lobulated lesion we have started seeing at the periphery, and the optic nerve is now started to be very clear. So this was a case of a spontaneous suprachoroidal hemorrhage, which has sort of resolved on its own after a few months. It's not completely resolved. It resolved on its own, and we have started seeing the suprachoroidal hemorrhage very clearly. And there was an associated vitreous hemorrhage in front of the optic disc, which was masking our diagnosis earlier. At this stage, I told him that, okay, fairly good, you don't have a mass lesion. So he said, I don't want to do anything at all. And therefore he disappeared again and came after 2 years. If you see here, the suprachoroidal has almost subsided, but his vitreous hemorrhage has come out with a PVD attached to the disc, right? So a suprachoroidal hemorrhage can always mimic a mass lesion, but one needs to be very careful as a differential diagnosis in adult age group in Indian circumstances. Ultrasound in trauma, one needs to remember this very carefully, that in trauma, pictures can be very confusing. So my suggestion to you is, what normally situation occurs is when a case comes for trauma, we do a primary examination, primary suturing, and the patient is sent immediately for an ultrasound. Whatever report comes remains with the patient, whatever it is, RD, PVD, hemorrhage, whatever. Then patient is told that you need to rest for a week or so, and then a vitreoretinal opinion is taken, and the vitreoretinal surgeon after 10 days operates on a report of an ultrasound which was done 10 days prior. Now, I have to tell you that in trauma, situations in the vitreous cavity are very dynamic. And if any surgery is to be done in the vitreous cavity, it has to be, you have to do an ultrasound just prior to that, because it will change. Look at those two scenarios. I did the case of trauma ultrasound on day 1. Looks like a vitreous hemorrhage. Doesn't appear to be any RD. The patient came to me after a week's time. The hemorrhage got absorbed and an RD has developed. This is a scenario here where I thought that there is a vitreous hemorrhage, and this probably was, according to me, an initial diagnosis of a retinal detachment with subretinal hemorrhage. And this patient came after 10-15 days. The entire vitreous hemorrhage has got absorbed, almost another thick PVD attached to the disc. Retinal detachment suspect early has disappeared. So mimic situations can mimic differently as initial stage of trauma. Over a period of time, the situation will change. So one needs to repeat an ultrasound. If he has no view of the fundus, you need to repeat an ultrasound just prior to any second surgery that you plan to do in trauma. Intraocular foreign bodies, I would like to tell you that intraocular foreign bodies are weird. They sit in any corner of the eye and can really cause a lot of havoc. So one needs to play around with the machine here. Look at this foreign body. It looks like a very bright foreign body with echogenic shadowing, and when I reduced the gain, the foreign body was only this much. All this was shadowing coming out. This is very classical of a glass foreign body. It produces reverberation artifacts. It's called as echogenic shadowing. And look at this case here. This was a case of trauma which I suspected looks like a foreign body, but I am not very sure. This is the optic nerve, so there is no shadowing coming out from here. And when you reduce the gains for a foreign body setting, you will see that the foreign body is strikingly seen very well. Rest of the things reduced. Okay. Same thing happens in the orbit, because the orbital fat and the foreign body have the same almost texture. So one cannot differentiate a foreign body in the orbit because of the surrounding fatty tissue, and one needs to play around with the gains to really see the foreign body there. Last, I will just like to take a few words on how we use now a 20 megahertz probe, which has a little higher resolution than 10 megahertz, to give us more idea as to what's happening into the vitreous cavity. These are two patients with a 10 megahertz probe, and this is a 20 megahertz probe. Just it looks a little better over here, but in this cases like this hemorrhage and suprachoroidal hemorrhage, we don't require a 20 megahertz probe. What we require is in just few situations. Look at these two patients. There is a small elevated lesion over the retina and choroid here and near the posterior pole. They both look very similar on ultrasound. Is this a mass or not was a question which was raised earlier. So I used a 20 megahertz probe in this. You can see that this is a retinal elevation with some amount of fluid over there. So this is not a mass lesion, whereas this remains solid on a 20 megahertz. So this is a small solid tumor which needs to follow up. This is how the resolution helps. Optic disc is seen very well on a 20 megahertz probe. This is a small little suspected drusen, where there is a buried drusen which is seen very well with 20 megahertz. And sometimes early optic disc cupping can also be picked up if they is seen very well on a 20 megahertz probe. Sometimes we can see large PEDs also on a 20 megahertz probe very well. We know what is the status happening, but here you don't require an ultrasound. Actually, OCT is much superior. But I'll tell you where it is given. Even cystoid macular edema can be seen very well on a 20 megahertz probe. See the traction on OCT and see the 20 megahertz picture. Very, very similar. Okay, but if there's a clear media, all this is nonsense. You have to rely more on the OCT. Again, seen very well over here. So my idea is I call this opaque media OCT. What happens if there is vitreous hemorrhage? You can't do the OCT at all. What happens if there is a cataract? What happens if there is a corneal opacity? We can't do. But in that stage, this 20 megahertz tells us what is the status of the macula. Look at these three patients. Dense vitreous hemorrhage. Here is the elevation of the macula. Again, organized vitreous hemorrhage. If you look at this macula, this is abnormal. This alerts the vitreoretinal surgeon. Again, there is a traction over the macula because of the vitreous hemorrhage. This the surgeon would know better if he had done an ultrasound very carefully. So this is also called as opaque media OCT. It's not mentioned in any books. This is what I call it. I just give you a few cases of how 20 megahertz was useful. This was a patient who presented to me with leukocoria, small child. If you look at this scan, there's hardly anything. Probably this lens shadowing out here. I was not sure, but here a very bad leukocoria. So we put this patient on a 20 megahertz probe. You see a small membrane here in the anterior vitreous cavity which is attached to the posterior capsule. This is a case of anterior PHPV and which was not picked up on a 10. They are thin flimsy membranes. They cannot be seen on a 10 megahertz probe. Case of cysticercosis, which we picked up very well on the ciliary body on a 20 megahertz probe. And then subluxation of the lenses can be seen very well with vitreous coming out into the anterior chamber. This is the entire zonules which are gone. Okay, and the posterior capsule can be seen very well with the posterior polar cataract, that it is intact, and there is posterior lenticonus which is seen on a 20 megahertz probe. This is the last slide that I want to show you. A little interesting case. These were a doctor couple, both of them homeopath. They came home on a motorcycle, and the husband told the wife that I am feeling some irritation in the eye. So the wife took a torch and looked at his cornea, and she saw a small little speck on the cornea. So she said, there is some foreign body and you don't need to go to the ophthalmologist, so I will remove it for you. So she took a 20 ml syringe, filled it up with saline, and put a needle in front of you and said, I'll flush the foreign body out. So she put it in front of the eye and she tried to flood it. While doing that, what happened was that the needle came out of the syringe and it went straight into his eye. So on the UBM, you can see this track. This is the track through the cornea. The needle hit the anterior capsule, went through the structure of the lens, broke the posterior capsule, lens matter into the vitreous cavity. Fortunately, the needle stopped over there, and your remote out patient had to undergo lensectomy, vitrectomy. He is a very fine person right now. So you should have a very high resolution ultrasound probe and in a good clinical history, and the findings will be helpful. Different clinical patterns will come to a conclusion. Do not jump to a conclusion in trauma. Follow up these patients, especially before you doing any surgery, and then good utilization of the machine. I told you, you need to play around with the gains to get a complete picture on ultrasound. Thank you.